Good morning, good afternoon, good evening, friends, depending upon which part of the country you are joining us from. I am Dr. Vijay Agarwal, President of CAHO, welcoming you all to this 40th episode CAHO ISQua International Webinar on Resilience in Healthcare. So I'm extremely proud today that we have a very young, energetic, our moderator, Dr. Rajat Arora, who is an interventional cardiologist. He is the group director of the Yashoda Group of Hospitals. He is a person who has done his executive MBA from Kellogg. He is also heading the Cancer Institute and the North India's first IVF chain in-house genetic testing lab, Gene Strings Diagnostic Center in Delhi. Dr. Arora is a very keen on providing compassionate care to the patients, and that's what sets him apart. So to introduce to our illustrious speakers and to moderate this, I hand over this to Dr. Rajat Arora.
Thank you, Dr. Agarwal, for the kind words. And let me go straight to the topic. Good evening to all. A very warm welcome to all gathered here today with us on this platform. And a big thank you for our esteemed speakers for taking out their precious time from their packed schedules to share exceptional insights on something that has become central to all healthcare discussions in today's world. Consider this: a new baby in Sierra Leone, an elderly woman in India, a malnourished child in Venezuela. Without the right care at the right time, each of these lives has a high chance of ending before it should. I'm Dr. Rajat Arora, an intervention cardiologist and group director of Yashoda Group of Hospitals based in India. Before we get started with our core discussion, I would like to bring your attention towards some of the most detrimental crises facing us today. Today, the world is embroiled in wars and crises. Conflicts in Middle East and beyond cause unimaginable pain. Here's a quote from UN press coverage. Today, the world is facing the highest number of violent conflicts since the World War II, and 2 billion people, mind you, my friends, 2 billion people, a quarter of humanity lives in places affected by such conflict. According to the new data, an estimated 14% of the people in the world were within 5 kilometers of violent conflict in 2023. Healthcare is a fundamental human right, but without health workers, there can't be a health service. And the world has been grappling with serious shortage of healthcare workers like never before. I'm sure all of us have heard recent news, with the global shortage of staff, global movements of medical professions is being resorted to. In UK is facing a shortage of doctors. And you would all remember this news a few days back. UK NHS will recruit 2,000 plus doctors from India, and on a fast track basis. There were days where Indian doctors wanted to go to UK, but not anymore. So UK is trying to get us to their country on a fast track basis as an initiative to address the acute shortage of medicos in the country. Another one, and not too happy one, addressing the shortage of nursing, allied health and medical professions in Western Australia, with forecast indicating a requirement of additional 5,000 doctors and nurses by 2033, the Australian health minister, who was here recently, said, and I quote, "We need nursing, allied health and medical professions from India." Then again, as per our WHO Director General, 55 countries with some of the world's most fragile health systems do not have enough, and many are losing the health workers to international migration. Ladies and gentlemen, we will be 18 million short of healthcare workers by 2030. Of these, nurses make up half that gap. And I would like to draw the attention of what CAHO is doing is training as many healthcare workers, and we must all applaud together for the work that CAHO is doing in training all of us and training more and more healthcare workers. Another one, by 2050, people aged 60 years and older will increase to 2.1 billion from 1 billion in 2020. Mind you, they will all need our care. Climate change, a growing number of disasters, political instabilities, and economic turmoil leave the global community desperate for systems that can cope. Goes without saying, resilience is the need of the hour. despite an unequivocal call for resilience in healthcare, a lack of agreement and vision as to what it actually stands for slows down the joint effort of policymakers, clinicians, and patients to build healthcare systems characterized by resilience. Therefore, it is important to clarify the concept's meaning in healthcare. And today, I'm thankful to CAHO and to all the speakers who've spared their time to be here to discuss resilience in healthcare. Without further ado, let's get started on what is needed and what can be done to avert such crises in future. As our first speaker, we have with us Professor Axel Ross. Professor Axel Ross is a surgeon and was heading Department of Surgery at a county hospital in Jönköping, Sweden from 2004 to 2012. He's also been Chief Medical Officer at the county hospital. Currently, he's Associate Professor at Jönköping Academy at the Jönköping School of Health and Welfare at Jönköping University with research in education and patient safety. He's also a research leader at Jönköping County. He's also Chief Medical Officer. He's also member of Swedish National Patient Safety Coordination Group in the National System for Knowledge Management of Healthcare in Sweden. Let me welcome Professor Ross. Here to you, Professor Ross.
Thank you. It's very good for us to be here to present and discuss resilient healthcare, a topic that's sort of very close to our hearts, both to mine and to Tarcisio and Cecilie. We are all members of the Resilient Healthcare Society, and I think that it's that capacity that we have been approached to present. Our presentation is about the basics of the concept of resilience in healthcare. And after that, Tarcisio and Cecilie will take you further into what resilience in healthcare is. I will start off with some more or less boring definitions. You have to start somewhere. And here I display a definition of the concept of resilience, and the another one is of the concept of resilient healthcare. And Erik Hollnagel in 2015 stated that a resilient system is a system that can adjust its functioning to prior to, during, or following events of different kinds, and thereby sustain required operations under both expected and unexpected conditions alike. Siri Wiig and colleagues took that further a couple of years later in their definition of resilient healthcare, defining it as a system's capacity to adapt to challenges and change it at different system levels to maintain high quality care. So what we see here is that we discuss resilience and resilient performance as system properties. It's something that's intrinsic in systems, like, for example, healthcare. Of course, there's a connection to individual resilience, but the main thing here is to discuss what's in the systems. So what has resilience in common or in connection with safety? Well, it's all down to that we realize that modern healthcare systems today are complex, as Dr. Arora touched upon as well. Shortening of staff in different parts of the world has impact on other parts of the world, as an example of complexity. With complexity follows changes, disturbances, challenges, and opportunities. These are words that we recognize from the definition about resilience from Professor Hollnagel. And of course, safety in healthcare has to address the complexity in healthcare. And hence, safety in healthcare is related to resilience in healthcare. So I will just touch a little bit about safety and what do we mean with safety and what do we mean with being safe. When we think about safety, we usually think about accidents, or rather that accidents don't happen. We do think about events that has adverse outcomes, and we say that a system is safe if as little as possible goes wrong. This is the traditional way of speaking about safety. We think about safety as something or a condition where the number of adverse outcomes is as low as possible. And we then define safety by its opposite, by the lack of safety. And then the premise for safety is the need to understand why accidents happen. As has been displayed in this picture, that's from the WHO and how they explain how you should work with safety. You should identify and measure harm. You should try to understand the causes, identify solutions, implement and evaluate these solutions, and then translate them into ordinary work. So that's one way, the traditional way of defining safety. So what we do with that is that we manage safety by snapshots. This diagram shows events that develops over time at the workplace, say in a ward, in a hospital, in a healthcare system. Most things goes pretty well. They sort of are above a threshold of unacceptable performance. Some things go very well, something doesn't go that well, but not that bad that an unwanted event happens. But sometimes they still do, but they are rare. So this is why we say that we manage safety by snapshots with this kind of traditional way of seeing safety. What we do then is that we know something about how failures happens, but we do almost know nothing about how work goes well. All this work that's sort of displayed in this gray area here. So that's one of the problems with seeing safety in the traditional way, that we only focus on things that go bad. Complexity is important to understand in modern healthcare. And in a complex world, everyday work has to be flexible to cope with the variability that we see in complex systems. People work and do their best, even if that's on an oil drilling platform that's on the picture on the right, or at an emergency room, the picture on the left. They use different kind of resources to fulfill their work. And these resources, as we know, may be limited and uncertain. People adjust to working conditions in the best way they can, and they do that with the resources they have. But since these resources may be limited, the performance they make might not be as good as they would have wanted them to be. The adjustments you do, they are inevitable and necessary. And because of these limitations in resources, the performance adjustments will always be approximate. It's because of the variability in the performance, or the capacity to be variable in your performance, where you adapt to the ever-changing circumstances. It's because of this variability that everyday work is safe and effective. But it's also, regrettably, on the other hand, it's because of this same variability that things sometimes go wrong. This leads us to thinking about safety in a different way. When we focus on safety as something that's related to that everything goes right. And in this sense, we can define safety as a condition where the number of successful outcomes is as high as possible. It's then the ability to succeed under these varying conditions. And when we then focus on safety, we shouldn't focus on the bad events. We should focus on everyday events, at that which happens when nothing happens, when work just goes on as it should. So when we in this way try to or want to manage safety differently, we must understand how and why everyday clinical work goes right. And this then provides the basis for understanding the functioning of the system and how safety may be created. And this really is the focus of resilience, to understand what happens in the everyday work. Resilience is an expression of how a system, that may be people, groups, and organizations, cope with everyday situations by adjusting their performance to the conditions. It's truly about understanding how people muddle through their everyday work, because that's what we do. So then back to the definitions. It's the same slide once again. Resilient healthcare is a healthcare system's capacity to adapt to challenges and changes at different system levels to maintain high quality work. It's an intrinsic system property, and resilience is then something that is created. It is something that's done in the systems. And resilient performance then requires that the system, the organization, the people who works in the organization, they have the potentials to respond to what happens, to monitor what is happening, to anticipate what might happen, and to learn from everything that happens, to respond, to monitor, to anticipate, and to learn. And I will exemplify this briefly with describing how an outbreak at the NICU at the hospital here in Jönköping was managed. And we studied that outbreak with our resilient healthcare glasses. So this was a rather small outbreak. It's a couple of years ago. We had 5 infected children, but we had no case of severe invasive disease. And according to our procedures, we then had an outbreak group leading the work without the containment of the outbreak. And of course, the engaged persons in the setting were physicians, nurses, assistant nurses. And since this was in the summer in Sweden, there was also holiday replacements, managers, parents, and relatives, of course. They were all in this system. And this was a small study. It was a qualitative study. We used the content analysis to analyze notes from the outbreak group. And also we did some interviews with engaged staff, leaders, and with persons from the outbreak groups. And we categorized our findings in relation to the potentials of the resilience I mentioned before, to respond, to monitor, to anticipate, and to learn. Just to give you some examples of what these words stands for. So what we found related to the potential to respond, we found that that was evident both in the outbreak group and amongst the NICU staff. And we found that in activities according to routines and also in activities that were adaptations to the events and the situation during the outbreak. And I've exemplified this with some quotes. We did what we were told to do, sometimes even more. As an example of that, the NICU staff responded and acted according to the decisions from the outbreak group. And also that we manage anyway, as an example of that. Sometimes the decisions taken from the outbreak group were unclear or difficult to adhere to, but still the staff did something. They acted, they responded. Examples from for monitor was that we saw that monitoring was part of the work in the outbreak group, but we didn't see anything from monitoring as a part of the staff work. We saw that, for example, in how they took different kind of cultures to detect new infections. They kept a list of bed occupancy, quite simple monitoring thing, but they also kept and daily updated the available beds at other NICUs in Sweden, because we had to transport children to other hospitals because of this situation. So these were things that were used to monitor what was going on. And also, when it come to the potential to anticipate, we saw that was related to evaluate future events, to be prepared, and to be informed of relevant important factors and things that could happen, so that they were prepared to act. For example, from the outbreak group, there were quotes like, "If these cultures turn out positive, we will." So they were sort of prepared to act when something happened. And lastly, then, to the potential to learn. Learning was evident in many parts. We saw that, for example, they changed their pattern of daily staff meetings to be able to quicker spread word, to quicker tell each other what to do in different parts of their work. And very interesting, they changed their view of where the risky situations were, and that was a part of their learning. They found that parents were more careful than staff, so they could leave some of the tasks over to parents instead of keeping them with the staff. And new procedures that were developed from the outbreak group that were thought to be safer was discarded by the staff, since they were then seemed as unpractical and unsafe in reality in work as done. So these were examples about how we understood how people muddled through the work with outbreak, as an example of resilience. And also we could categorize our findings according to these 4 potentials: to respond, to monitor, to anticipate, and to learn. So these were my slides to start with, to just give you some basic thinking about resilience and resilient in healthcare. Thank you.
Professor Ross. If I may just say a few words, we must all remember resilience is, as Dr. Ross said, resilience is an expression of how a system cope with everyday systems. And resilience performance has the potential to, 1, respond, monitor, anticipate, and learn. And Professor Ross, I must tell you that, ESBL has been a very common problem faced in our ICUs on an everyday, and I think our healthcare workers fight together as one team to do the best practices to reduce the ESBLs in our ICU in our hospitals.
Yeah, thank you.
Bringing me to the next speaker, here's something interesting about the word resilience. In the English language, the first definition derives from Francis Bacon as the action or act of rebounding or springing back, rebound, recoil. Resilience is a word that we first learned in our physics, maybe in our 9th or 10th standard. This is so nice that, now there is a concept of resilience in healthcare. In the 18th century, the mechanical usage of the term began. Our next speaker is a full professor of industrial engineering department. So I would like to add some of the words from engineering. In engineering science and practice, the resilience meant elasticity. However, in the real popularity of this notion has exploded in practical, academic, and discourse during the last 45 years. Nowadays, the concept of resilience is known in physics, engineering, disaster management, psychology, sociology, and of course, in public health. Our third speaker, and I'd like to invite Professor Tarcisio Abreu Saurin, is presently serving as a professor in Industrial Engineering Department at the Federal University of Rio de Janeiro in Brazil. He's He's a industrial department. He's in industrial engineering department of the Federal University of Rio de Janeiro, Brazil. He holds a PhD in industrial engineering, an MS in construction management, and BS in civil engineering. His main research interests are related to resilience engineering, safety management, lean production, and complexity theory. He's carried out research and consulting projects on these topics in healthcare, construction, electricity distribution, and manufacturing. He also has supervised 73 postgraduate students and authored a number of journal papers, book chapters, and conference papers on these topics. Here's to you, Dr. Saurin.
Okay, thanks for this introduction, Aurora. I will share my slides from my side. Okay, can you see my slides?
Yes.
Hello?
Yes.
Yes, yes, we can see you.
Okay, so I will present some additional practical examples regarding resilient healthcare based on Axel presentation of the fundamental concepts. The title of my presentation is Practices of Designing for Resilient Performance, the Role of Huddles and Rapid Response Teams. First of all, let's define what I mean by designing for resilient performance. We have here a proposed definition. It's the use of design principles to support integrated human, technical, and organizational adaptive capabilities. An underlying assumption of this definition is that resilient performance arises from the informal self-organization of healthcare professionals on the spot, and also from resources and structures deliberately designed to support resilient performance. My presentation will be focused on this design portion. In a prior study, we came up with 7 design principles for resilient performance. They are listed on this slide. First of all, we should develop functional models of how the healthcare system works. The assumption here is that before making any intervention, we should develop a deep knowledge of how the system works. The second principle states that we should design to make variations in performance visible. This is related to the monitor resilience potential mentioned by Axel. The third principle states that we should design standards that best fits the nature of the function. The point here is that there might be different levels of detail for standards in a health service, more or less detailed standards. The fourth principle, this is a very important one. I like this one very much. It states that we should design slack resources and strategies. By slack resources, I mean extra resources, redundant resources, double checks in medication administration, and this type of thing. The fifth principle states that we should design to support acceptable performance under degraded conditions. The importance of this principle was very clear during the COVID pandemic because hospitals had to work for a long time under degraded conditions. The sixth principle states that we should design to leverage diverse perspectives. This is crucial in healthcare because we have several stakeholders. Each stakeholder has different needs, different perspectives. And the last principle states that we should design to support learning at the individual and organizational level. So you can see that these principles are, resemble a little bit the 4 resilience potentials mentioned by Axel in the prior presentation. We also developed what we call a knowledge framework of design for resilient performance. It's represented here as a pyramid. On the bottom, we have the concepts regarding the philosophical assumptions, what we mean by resilience, what we mean by design for resilient performance. In the middle, we have the principles mentioned on the previous slide. They provide high-level guidance to work system designers. And on the top, we have the practices, which are designed managerial processes and tools that operationalize the principles, necessarily including a human component. These practices can encompass, for example, rapid response teams, huddles, ward rounds, morbidity and mortality meetings, and several others that are usually already in place in health services. I will discuss now an application of this knowledge framework in our university hospital in Brazil. It's a fairly large hospital for Brazilian standards. There are about 900 inpatient beds, 150 ICU beds, and about 6,000 employees. We selected for this application rapid response teams, which are representative of a broader family of practices referred to as teams on standby. And the other practice was representative of several types of meetings that happen in hospitals. In this case, we selected the daily huddles at the emergency department. A brief introduction on rapid response teams. We have a large audience here. Maybe not everybody is familiar with this concept. The purpose of these teams is to identify ward patients whose condition is deteriorating and then provide early notification to responders, rapid intervention, and evaluation of the processes of care. There are usually some triggers for calling the rapid response team. For example, triggers related to airways, breathing, blood circulation, state of consciousness. And these triggers are monitored by the efferent arm corresponding to those who monitor the patients in the ward and call the rapid response team. And there is also the efferent arm corresponding to those who respond to the call. And a brief overview of the second practice, the huddles at the emergency department. In our hospital, there are two main types of huddles. One for critical patients, in which there are about 2 minutes of discussion per patient on average. And there is another huddle for non-critical patients, in which the team takes about 50 seconds per patient. In both huddles, the focus is to discuss patient flow and ED capacity management. So the discussion revolves around who is expected to be discharged, who is expected to be transferred from one unit to another, how many patients are expected to maybe arrive in the near term. So the focus is not about the clinical condition, but it's about the patient flow. Here is an example of how we organized the tables with the findings of the assessment. On this slide, we have some findings related to the assessment of the rapid response team. We have the principles on the left-hand side, and on the right, we have some comments on the principles. In red, we have some situations in which there are improvement opportunities and problems. For example, regarding the principle on functional models, we found that some variabilities that frequently occur, such as simultaneous calls of the rapid response team, could be anticipated in the standardized operating procedures. The SOP are examples of functional models, and they could anticipate the situations and provide some guidance to the teams on how to cope with these situations. An example related to the visibility of performance variations, it's in green because it was, we found good practices, desirable performance. In this case, we found that there was real-time monitoring of vital signs of patients through sophisticated equipment. That's typical of large hospitals, but anyway, this is a good example of using this principle. On this slide, we have some examples related to the assessment of the hurdles at the emergency department. For example, on the top, findings related to the principle on slack resources. We found that the normalization of resources and strategies for coping with overcrowding tended to increase workload of professionals besides providing suboptimal care. So overcrowding was actually the main issue, the main problem in this ED. And as the situation became normal, this was detrimental to the performance of healthcare professionals. An interesting example related to Principle 5, acceptable performance under degraded conditions. We found that the triage at the ED changed according to ED occupancy. For example, if there was overcrowding, self-referred patients were no longer accepted. They were referred to other units of the healthcare system. It's also possible to carry out other types of analysis. I don't have time here to go into much detail, but it's possible to assign scores to each principle. We developed a scoring system where 0 means worst performance and 1 means best performance. And it's possible to develop pictures like this. We can see here the principles, the acronyms, standardization, visibility, learning, slack, and we have here the scores. And it's also possible to explore the relationships between the principles. Here's an example of a generic model of the relationships. We can see here, for example, that the principle on slack depends on the principle on visibility and on the principle on functional modeling. So it's possible to develop better action plans based on this model. So moving on to the conclusions, based on our experience of applying this framework so far, we think that it has proved to be helpful to find resilience. It's not only about finding brittleness. It's not only about finding failures. It's about identifying how we can improve existing resilient capabilities. And it also offers insight into how we can reduce the human costs of resilient performance. By human costs, I mean here the stress, the workload, because quite often resilient performance rests only on the shoulders of healthcare professionals without proper organizational support. And so the point here is to develop supportive systems that help resilient performance. We have also applied this knowledge framework to inform the design of technical systems supportive of resilient performance. For example, we have been working on how we can develop digital technologies supportive of resilient performance. We have carried out a study in our blood bank in the university hospital, and we have been able to identify resilient requirements of digital technologies. For example, we found that the dynamic prioritization of orders in blood banks is an important resilient requirement for digital technologies in this environment. And We have also been very interested in applying this knowledge framework in how to design a built environment supportive of resilient performance. By built environment, I mean here the building itself, the healthcare facilities. I have here a very short example that illustrates these applications in the built environment. It's also in our university hospital. We had 3 medical on-call teams that they were located in different rooms and in different floors of the hospital. We had a rapid response team, a medical on-call team, and a nursing supervision team. We have here the pictures of their rooms before the intervention. And after the intervention, we designed a shared workspace for all 3 teams. We have here on the top a floor plan of the shared workspace, and here's some pictures. This was implemented last December, and we have carried out some preliminary assessment, and the reports have been very encouraging. The professionals have told us that learning has become easier because they can share information more easily. And the time saved from seeking for colleagues has become Slack resources. So you can see here that learning Slack, these are some of the principles that I mentioned in my presentation. So that's it. Thank you very much. This is a kind of industrial engineering viewpoint for resilience engineering.
For the insights, let me add a few points to it, if you would allow me. We have a rapid response team in India called, started by, a few years back by NABH, and people like Professor who are here at the helm of CAHO are the people who started the concept of NABH in India long back. And the rapid response team is called the Code Blue team. Very interestingly, these teams are, they would be there for the patient, particularly in wards, in matter of seconds, if not minute. And every hospital, I understand, and we work in, tries to minimize the time that they can reach out to the patients, and also they should have the expertise to resuscitate the patient at the time of the need. Very interesting concept that you also added, and I must say that is the future, is hemodynamic monitoring of all the patients in the ward. There are some startups in India which are trying to do this very well, I would say, but we are still far away from reducing cost and making it a mandate for at least basic hemodynamic monitoring continuously, not when nurses come and they do the hemodynamic checking of the patient over 6 or 8 hours or 4 hours, but a continuous hemodynamic monitoring with software that have analytic skills or analytic capacity to inform the doctors or the nurses that something right isn't there. With this, let me introduce our third speaker, who's also the associate professor at SHARE, that is Center for Resilience in Healthcare Faculty of Health Sciences at the University of Stavanger, Norway, Dr. Haraldseid-Driftland. Dr. Cecilie is a Bachelor of Nursing at Edith Cowan University, Western Australia from 2005 to 2007. She finished her Master's in Health and Social Science with focus on user perspective in 2009 to 2011. She's also PhD in Health and Medicine with the title Unsupervised Clinical Skills Training in Nursing Education, Active Student Involvement in the Development of Technology-Based Learning Tool. I have seen some of the publications that she's done. She's done multiple publications, and I understand that she's an expert in bringing resilient healthcare to practice. Inviting Professor, please.
Thank you very much, Dr. Arora, and thank you so much for having me. I'll share my screen. And here, hopefully you can see the correct one. So thank you so much for having me, and I'm so happy to be here to talk to you all. And this is such a great initiative to have these webinars. So I'm Cecilie Haraldseid-Driftland, and I'm having the third part of this talk, which is about learning tools. So when we talk about, maybe I'll just move this. When we talk about patient safety, and we often talk about numbers, and that's a bit hard, but in the broad sense of it, we can, strictly speaking, we can say that it is about 10% that both nationally and internationally, that any given time that goes wrong, like adverse events in the healthcare setting. Recent studies have shown that it might be as much as 24% that actually goes wrong. But the important thing here in terms of resilience in healthcare and resilient performance is that when 10% goes wrong, it is actually 90% that actually goes right. In patient safety, we have made our efforts towards these 10% and trying to understand what's happening when things go wrong. But we haven't been so good at looking at what is in those 90 other percent, which is actually quite a bit. So resilience in healthcare is about learning from all these events, and building on what both Axel and Tarcisio said, it's about seeing the whole picture and learning from everything and everyday events. But learning from positive events is actually quite difficult. And maybe that is because it's a quite new approach, and it's also because there is a lack of tools to help us do this. We have a number of tools that helps us to learn from what went wrong and what's not so positive, but we are not trained actually in trying to understand what we are good at and why. So what we need to learn from positive event is actually to understand what it is that we do that brings positive outcomes. We need to understand why those outcomes and those actions become positive. And we also need to understand how you can use this knowledge to actually improve your practice. Because if we know what it is that contributes to positive outcomes, we can actually also improve things that are not so positive. So in our project and in our work here in Norway, we have built on the definition of whole Nagel, which Axel was talking about, and we define it as a capacity to adapt to challenges and changes in everyday practice at different system levels to maintain high quality care. And what I like to draw your attention to is the two things about the system and about the complexity. And I want to say something about the system, and that we have a system perspective, because that is so important. It's not about the individuals, and it's not about everyone that has to work harder and run faster for a system to become resilient. The resilience of a system is about understanding how the system can contribute to resilient performance and how the system can actually enable everyone within the system to do their job in a good way. The complexity is important because this means that we work in adaptive complex systems. And opposed to a linear system where one package goes through from one place to another, the healthcare system looks a little bit like this. It's a bit chaotic. It's a lot of stakeholders involved. It's a lot of people going back and forth, doing all kinds of things. And this actually means that everyone within the system and the system itself at any given point has to create the safety by responding to what happens. And this means also that we don't have the luxury of anticipating at any given time what is actually going to happen. We have to work with what we got and try to solve tasks as we go along. So what is it that is important for resilient performance? In our study, we have done quite a lot of work to trying to pinpoint what resilience is about, because we want it to be operationalized. We want people to easier understand what it is about and actually help people translating this into practice by understanding what it is. In our work, which we have drawn on a lot of studies across the whole world and across different healthcare contexts, both hospitals and nursing home and home care, we have identified 10 different capacities that are important for resilient performance. And you can read more about this in this open available paper, but I'll draw you through some of it. So we know that competence, communication, alignment, risk awareness, coordination, and facilitators are very important. But what we also know important for contributing to resilient performance is actually the structure. Because in order to have a resilient performance of a system, we need to have very good structures in place. This means that there has to be clarified roles, who has responsibilities for what. It has to be procedures, it has to be everything has to be organized, and how we should do things and who is doing what to any given time. And if we know that, that is very important to have as a basis, because we need to be able to do adjustments, but we also need to have structures in the groundwork of it. Another thing I would like to draw on is leadership. And we've seen how important leadership is for enabling resilient performance. And the leaders has to facilitate, support, motivate, and contribute to the organization and the people within their team or their unit. They have to empower the staff and develop an inclusive work environment, but also to interact with different leaders and motivate staff, and being able to help the staff prioritize when there is conflicting demands of what they're going to prioritize. Another thing that is crucial is how we look at involvement. And this is important both for how we think about involving patients and families, but also how we involve co-workers and how we learn across different teams and units. So involvement is actually that you look at your colleagues or your patient or your families and say that we actually acknowledge that you have important information to this situation or this task that we're in, and actually acknowledge and help them become involved in whatever you're doing. The last thing which we have talked about previously, and which is my favorite, is the learning part, because we see how important it is to have a culture for learning. But this also means to have places like this where you can actually interact and learn from each other. It is important how we view the culture of learning and how we make room for learning in everyday tasks, and that we create places where people can learn across, for example, different wards or different units. So to further strengthen the learning potential and the importance of learning, we set out to develop a learning tool that we try to help improve resilient performance. Because as I said earlier, there is a lack of tools, and it's hard actually to change the mindset and doing something else. So what we realized making this tool is that providing healthcare is actually a very collaborative effort. We provide healthcare to collaborating with all our co-workers, with the patients and with the families. And since we work together, we also need to learn together. So we've made this tool so that we can sit together in a group and use it. And what the tool actually is an open and freely available web page which you can access whenever you want. And it's also recently been translated into English. And as you can see here, which is a screenshot of the start of the web page, it gives you a lot of small videos and explains to you how to use the tool. There is also the link and web address that you can use here. But I'll go through it and explain a little bit what it is about. So in the tool, you have 3 different elements. You have the mapping tool, which you can use to score yourself and how you think the current status of your team or unit is within resilient capacity. There is a scenario element where you can go into depth and actually trying to understand what it is that your team or unit do to provide positive outcomes. And there's also a short resilience reflection list that you can use during your everyday practice. So the aim of the first tool, which is the mapping, is to create awareness of areas of own team unit capacity for resilience. So in this element, you're actually introduced to all of the 10 capacities where they are explained what they're about, and then you're asked to answer 3 different statements for each of the elements. So this is thought that you should all stay together and work in a group and and talk about these and then try to score yourself on this totally agree to completely disagree if this is how you do it in your unit. So based on going through all these 10 capacities and scoring your 30 different elements, you are actually told what you are best at, because we know that you will very quickly talk about what you're not so good at and what can actually be improved, but we are not so good at talking about what we're already good at. So here you get an answer of what you're best at, and then we'll send you to the next element, which is the scenario element. And the aim here is to understand what your team does that provides positive outcomes. And to do that, we have used very everyday tasks where you are drawing up a report, your medication administration, or you get a new staff, or your training and skill development, or patient admission and discharge. Very easily everyday events, and trying to show you a small video of a scenario where something happens, followed by 2 small reflective questions. And these should also be reflected up and in a group. And then the point is here is to actually talk about what is it that we do at our unit? How would we handle this situation? And not how we would have wanted to handle it if we had, you know, more patient or resources or money or time, but what do we actually do in our unit? And talking through those things, you can actually create an awareness and pinpoint what is it that we do that contribute to positive outcomes. Because if you know that, you can try to strengthen it by applying it to other areas. So the third element is the resilience reflection list. And the aim here is to enable reflections during everyday practice. And for this, we have made just a short little list of 3 questions, which we hope you can use when you're at work, because the other 2 tools you might need to step away from your ordinary practice and to gather a group and talk through this. But we also want you to try to change your mindset of just trying to think about what went actually well and why, and then use the resilient capacities to understand what was it that contributed to this situation and then a positive outcome. Was it the structure? Was it the learning? Was it the leadership? Was it the involvement? Because then you can actually start understanding what it is that contributes to positive outcomes in your unit. So I'll leave a few more minutes for Axel, because he wants to round off with some information. But this is the QR code to the tool. And thank you so much for listening. And I'm available for questions afterwards. But Axel, do you want to say something about the resilient healthcare?
I will be very brief. We are all 3 members of the Resilient Healthcare Society. It's a small society. It's a worldwide society. We've got this web page where you can find more information. And if you can change slide, Cecilie, we have this meeting, a yearly meeting, and this year the meeting is going to be in Norway, in Stavanger, where Cecilie works. And I think there's another slide as well.
Yep, that's the last one.
Yeah, and you will find on the web page, you will find some of the publications that's come out of our cooperation in the Resilient Healthcare Society, and you will also find more information about our webinars and so forth. So welcome to visit our website to learn more about the Resilient Healthcare Society. Thank you.
Thank you. Thank you.
Thank you. Thank you, Professor Cecilie, for the great talk, and I must congratulate you for the great work you and your team and the Resilient Healthcare Society is doing. Back in college days, when we were students or junior doctors, we thought working 48 hours a day, or 48 hours back to back, doing night duties was resilience. But the work that you are doing has opened our eyes of what really resilient healthcare is about and what kind of teamwork it is all about. I must just to bring to the notice to our viewers that what she has mentioned is leadership empowering the staff that we must all remember. We must set our priorities right, and not just our priorities. We must communicate the priorities that we set to our people. We must involve not just the patient, we must also involve the families of the patients. And, a very interesting point that, she said is a reflection on daily basis. I would open the house for the questions if there are any.
It was a wonderful session. And I think a very fresh perspective on resilience in terms of what and how should we look at resilience in healthcare. And I don't think that any other system can be more complex than healthcare. And therefore, resilience is an integral need of the resolutions in healthcare. So extremely this thing, we are very happy to, Prakash, can we share our certificates of?
Yes.
This is as our token of appreciation. It will reach to you, to Professor Tarcisio, Saurin.
Thank you.
Thank you so much. Then Dr. Cecilie, Driftland. Thank you, madam.
Thank you.
And then Professor Axel Ross, quite a few, and we shall be delivering these certificates to your mail address.
Thank you.
Just our token, our appreciation, sir.
Thank you.
So,
Thank you very much.
thank you very much. And indeed, a great day for CAHO to get all of you here and be a part of this important webinar. Thank you. And thank you, Dr. Rajat Arora, for
Thank you,
so
sir.
beautifully moderating this session
Let me
and
just-
joining the CAHO's team of people. We are going to get you more and more involved in our
So it's always a pleasure. And let me also thank all the speakers who've taken out their precious time, shared their greater insights of resilience in healthcare. Thank you, CAHO. And I would take the opportunity from what Dr. Cecile said, the culture of learning in healthcare. Thank you, CAHO, for bringing the culture of learning to our community. Thank you.
Thank you so much, ladies and gentlemen.